Hey, this is Beth Wright, and I am providing you a podcast for the first unit of NUR 237, your last pharmacology course, and this will be about chapter 46, and we're going to talk about myasthenia gravis, Alzheimer's disease, and urinary retention. You'll have notes to follow along, and we'll talk about the disorder first and then cover specific information about medications used to treat this. So these are your exemplars, your medications that are going to be used to treat these different ones, and I put this up here because your test questions will cover your objectives for this chapter, for this unit, and it will also cover these specific drugs. So that's what you need to be concerned about when you're preparing to study for these for this particular unit. So you see there we've got neostigmine, donepezil, rivastigmine, bethanechol, and atropine. So let's first talk about myasthenia gravis. When I think about this particular disorder, I always think about muscles, and you can see the M starting the name of the disorder is M, so muscle, and it's, think about muscle gravity, okay? This is a disease that causes severe weakness of the muscles, and when you think about muscle gravity, think about gravity pulling those muscles down. One way to try to remember it, I guess, but it is painless weakness of the skeletal muscles, and that you'll see, and the results or the cause of this is because there's a deficit in that neurotransmitter acetylcholine. So that's what it's, that's the whole cause of it. And what you'll see with these particular patients, if you see them at all, a lot of times these clients, you're not going to see them in the hospital setting most of the time because they manage real well with medications, usually in the home care setting, but you may see it from time to time. But what they start off with is drooping of the eyes, like ptosis is the medical term for that, and muscle weakness of the face, and then it starts affecting, the rest of the body, and difficulty swallowing, speaking, and then eventually difficulty walking. And so again, what happens here is that neurotransmitter acetylcholine is not working, and it's because antibodies are made in the body attacking itself. So it's referred to as an autoimmune disorder, and so antibodies form, and they either block or destroy those receptors for the acetylcholine at the neuromuscular junction, which prevents muscle contraction. So that's how just a quick overview of how this disorder occurs. Now, think about that acetylcholine. What happens with that? The life of acetylcholine. What happens is, again, it's one of our main neurotransmitters of the autonomic nervous system, and it's formed in the cholinergic nerve endings from choline and acetylcoenzyme A, and it's catalyzed by the choline acetyltransferase. Okay, so once it's developed, it stimulates the cholinergic receptors, and once that happens, it's done its job and it's destroyed by the acetylcholine esterase enzyme. Okay, and that's it. That's the whole life of acetylcholine. So it's made, and then it does its job, stimulating the cholinergic receptors, and then it's destroyed. And of course, this is a continuous process that happens in the body. So it's destroyed by that acetylcholine esterase enzyme. And this is significant because drugs that are used to treat myasthenia gravis act indirectly by stopping or inhibiting that enzyme, acetylcholinesterase, and so when it blocks that, it keeps that acetylcholine in the system longer. So that's significant with the life of the acetylcholine. And this just shows you an illustration of the myasthenia gravis patho, where you see there the neuromuscular junction there, the muscle end plate, and you have those acetylcholine receptors or choline receptors there at the muscle, and you have the acetylcholine, which on the left side it's working just fine. But on the right side, the B picture, you see those antibodies that have been formed that block that exchange of acetylcholine coming into the choline receptors or acetylcholine receptors. So you can see how, that can happen with those antibodies. So when that happens, we don't have the muscle contraction that occurs. So, again, the antibodies form, causing a lack of communication between those nerves and those muscles, hence causing a lack of muscle contraction. All right, let's talk a little bit about Alzheimer's. And I know you studied Alzheimer's when you all were, I think, were taking nursing NUR 201. And so just another review of that. It's a common form of dementia, but the big thing here is our memory loss, and of course other intellectual abilities that affect daily life. Now, I'll tell you, individuals who deal with or the caregivers who deal with patients with Alzheimer's, it is extremely difficult for them. It's so sad to see that loved one with Alzheimer's being to the point where they don't know their spouse, they don't know their kids, and of course, that it starts off with slowly not remembering newly learned information, and then it starts progressing where they don't know the simple things. They don't know what a key does. They don't know what we take advantage of every day. They don't understand, or they've lost that cognitive ability, and it's just so devastating for family members, and they need a lot of support when caring for Alzheimer's patients. They also can have mood and behavioral changes as well. And there's several forms of Alzheimer's. What I've noticed is individuals who are afflicted with this disorder at a younger age, younger being adult, but mid-adult age, I guess, seems like that Alzheimer's disease goes really quick, versus the older individuals who are afflicted with it. It can last, up to 10 or more years. So very devastating for families either way they get it. But the patho of Alzheimer's is that there's a buildup of plaque and neurofibrillary tangles. Now, if you think about that word, neurofibrillary tangles, think about tangles in your hair, okay? Now it's fibrous tangles in the hair. So, oh no, that leads to eventual brain cell death, and causes all the neurodegenerative problems that we see with Alzheimer's. Got you a pictogram here that just talking about the 5 A's to Alzheimer diagnosis. And of course you see there amnesia, aphasia, agnosia, apraxia, and anomia. So those are different things that occur. You see the lady in the picture, she got a pot of flowers on her head and thinking that's a hat, but it's not a hat, half dressed. So again, very debilitating for individuals who are going through this. And then the urinary retention. So I know that really all doesn't go together. We've got the Alzheimer's, we've got the myasthenia gravis, and now we've got the lower end, the urinary retention. However, these medications that we're talking about will cover this. So when we talk about urinary retention, we've got to think about that this can be considered an emergency, because when you think about urine not going out of the bladder, what's going to happen with it? It's going to stay in and back up and back up and back up into the bloodstream. Yikes, this is not good. So anyway, there's some etiology behind urinary retention. Most common cause is a lack of that nerve innervation or connection between the nerves, and that is known as a neurogenic bladder. When the bladder is failing to store urine, it's referred to as a spastic bladder, and if we can't empty the urine, then it's a flaccid bladder. When we think about the clinical manifestations here, a urinary retention is where the bladder has a sensation of being full, or there's incomplete bladder emptying. And so the spastic bladder results from that a lesion in that neurogenic or neurological area above the level of the sacral micturition reflexes. Micturition is basically urination, and the flaccid bladder results from lesions at the sacral micturition reflexes as well. So these are some of the drugs. The cholinergic drugs stimulate the parasympathetic nervous system in the same manner as acetylcholine. And so when you think about that, you got to think about what's happening when we have that parasympathetic nervous system response. Now these meds can either be directly or indirectly acting, and anticholinesterase drugs, which remember the cholinesterase is what destroys the acetylcholine once it's done its job. So those are some of the drug classes that's going to help take care of these. And anticholinesterase drugs inhibit the anticholinesterase. Okay, so let's talk about them specifically. The neostigmine is an indirect acting cholinesterase. Again, it decreases the inactivation of acetylcholine by affecting that enzyme acetylcholinesterase. Okay, and that causes, when we don't have that acetylcholinesterase, that means that we've got an increased accumulation of the acetylcholine. And so that helps with that muscle strength and muscle tone. And its main use is for myasthenia gravis, both in diagnosing and treating. Now, adverse effects of these medications, you got to think about what's going on with the with the parasympathetic nervous system. When the parasympathetic nervous system is activated, we know that it can affect the heart rate. It can drop the heart rate. We know that it constricts the bronchial tubes. It can constrict the bladder. It also causes skeletal muscle contraction, and it also stimulates that vagus nerve. Okay, so keeping that in mind, we have to then think about these are going to become possible adverse effects of a medication that increases the accumulation of acetylcholine, which affects the parasympathetic nervous system. Okay, so if you look at those adverse effects, we have to suspect or watch for dysrhythmias, a decrease in our cardiac output, low blood pressure, syncope, and of course cardiac arrest. Not good. We can get too much cholinergic or acetylcholine in there, which will or can cause a cholinergic crisis, and with that we start seeing respiratory depression and other problems. We'll talk about that in just a second. Other adverse effects respiratory, we can see an increase in secretions. We can see laryngospasms and bronchospasms because of that constriction of the bronchioles. We can also see shortness of breath and respiratory paralysis. So if in a cholinergic crisis, what has to be given is an anticholinergic, and the drug of choice for that is atropine. So that's an antidote for a cholinergic crisis. Contraindications, of course, anybody allergic to the medicine or hypersensitivity, any kind of lung disease such as bronchial asthma, and that'll be something consistent throughout these medications that we'll see. Also, sick sinus syndrome, a cardiac disorder, and what that is a sick sinus syndrome. Okay, so that meaning the sinus node is sick, and you can see arrhythmias develop, either tachycardia, bradycardia, or a mix of those. Usually you'll see sick sinus syndrome with older individuals. It's rare to see it in younger adults. Nevertheless, it can happen to anyone, and sometimes they have to do a pacemaker in order to treat that. Also, we have to use caution with patients with benign prostatic hypertrophy, or BPH. So basically a problem with our prostate there with the males, and also urinary retention problems. You have to use caution. So there are, for nursing implications, there are several interactions, drug-drug interactions with neostigmine that can either increase or decrease its effects. With the administration of the medication, you want to give it with foods or fluids, and watch about extended release medications and not crushing those, and inform the family not to crush. Now, I found this on nursestips.com. Had several different things there to help remember mnemonics, that kind of thing. But when we're talking about cholinergic crisis, we're talking about somebody who's had too much cholinergic medication. In this scenario, too much acetylcholine is causing a crisis, and so we know we have that cardiac and respiratory issues that happen, but also these are some other things that can happen with a cholinergic crisis. So diarrhea, cramping, abdominal cramping and diaphoresis, sweating, urination, meiosis, bradycardia, or tachycardia, emesis, nausea and vomiting, lacrimation is tearing, and lethargy and salivation. So these are symptoms of a cholinergic crisis. And of course, our antidote for that is atropine. Okay, now we're looking at the drugs used for Alzheimer's, and this particular one is donepezil, and it increases the acetylcholine by inhibiting the metabolism of it, and that helps elevate those acetylcholine levels. And it's primarily used to treat Alzheimer's, although it has been used to treat other things with neurological disorders such as multiple sclerosis or myasthenia gravis. Most common adverse effects: headaches, dizziness, depression, vertigo, nausea, vomiting, diarrhea, abdominal cramping, and anorexia. Serious adverse effects, again, can be breathing problems, asthma, COPD, fainting, heart disease, or GI bleed. And of course, contraindications are the same: bronchial asthma and sick sinus syndrome. And watch about drug interactions that can increase the effectiveness and actually cause a risk of toxicity of this particular drug. So we want to prevent those drug interactions. And, by doing that, we know we need to look at the drugs that the patient's on. With administration, we should give this medicine at bedtime each day, and be sure for the oral disintegrating tablet that they dissolve on the patient's tongue. And of course, we're going to assess for medication adverse effects, as well as evaluate for medication effectiveness. In other words, is their memory doing better? So we always want to be evaluating effectiveness. And I've got you another pictogram. This is the donepezil. The trade name on it is Aricept, and so you can look at that one. We want to start at the lowest dose. It can be increased to help with the symptoms, but of course, anytime we increase doses, we also have a risk for increased adverse effects as well. And you see the gentleman's using toothpaste to brush his hair there, so very confused and memory problems. This is another type of medication used, rivastigmine, for Alzheimer's disease, and it is a long-acting central anticholinesterase agent that helps with keeping that acetylcholine abundant in the body. And so it's used to treat mild to moderate dementia, and also can be used for Parkinson's disease. Same type of adverse effects can occur with that. Same kind of contraindications occur with that. And nursing implications. This medication does come in a patch, so remember about how to administer those kinds of medicines as far as how often do we change them. It also comes in the oral form as well. And then our last but not least medication is the bethanechol, and it is a direct acting cholinergic medication. This is used for urinary retention, and it increases the muscle tone of the GI-GU tract to help the urinary bladder to empty. And also, you may see this medicine used in the post-op period, because that's where we see urinary retention a lot, for acute post-operative or postpartum areas to treat urinary retention. So adverse effects, we can have cardiovascular issues where we could have heart block, orthostatic hypotension can occur, and cardiac arrest if it's given in large doses. So we got to know what's going on with our patient. We got to do a good cardiac assessment of the patient, and that would be, an ECG, getting an EKG or ECG, listening to the apical pulse for at least 1 minute. Orthostatic hypotension, knowing how to check for that. We do the blood pressure, lying, standing, and sitting, and watch for a drop in that as we change those positions. We also need to look at our GI adverse effects, and other adverse effects can be flushing, urinary urgency, sweating, malaise, and dyspnea. And our contraindications for this are going to be, any hypersensitivity, of course, hyperthyroidism and peptic ulcer disease, any kind of intestinal obstruction, asthma, bradycardia, coronary artery disease, epilepsy, and Parkinsonism. Those are some of our contraindications for this particular medication. And there's several drug-drug interactions that can cause an increase in the blood pressure. So again, we got to look at those list of meds that the patient's on. We want to prevent those interactions, and of course assess for those med adverse effects, as well as evaluating effectiveness of the medication. So with this particular medication, do we have urine output? That's what we're going to be looking for. That concludes the podcast.